Good evening, everybody. It is 7:30 in South Africa, and welcome to the October Open Hand Therapy Initiative webinar, brought to you in association with the University of the Witwatersrand in Johannesburg and the South African Society of Hand Therapists. Today's webinar, we will be chatting about Quervain's Tenosynovitis, therapeutic gains for a tiresome pain. And this will be followed by a time for questions and discussions. And we're very privileged to have Mary-Jane Nqwena and Jaqui Eksteen join us to share on this condition and its management this evening. If you have any questions, you are welcome to contact us, but we're now going to introduce our first speaker for the evening, Mary-Jane Nqwena. Just give me one moment to stop sharing. It is a privilege for us to have Mary-Jane with us. Mary-Jane did her occupational therapy degree at Stellenbosch University in 2004. And then she went on to do her community service in Port Shepstone in KwaZulu-Natal. And after that, I moved to Ireland in the United Kingdom for a while and worked there. She then returned to South Africa and started working for a non-governmental organization that provided seating. And then she moved into private hand therapy. She then working for a private practice in Cape Town. After that, she moved into the public sector, where she was responsible for establishing a hand therapy service at a district level hospital in Cape Town. And then later moved to the Eastern Cape, where she started her own private practice in hand therapy in East London. Mary-Jane is a wife and mom and lives in the Eastern Cape. And it is a real pleasure to have you here this evening, and we're looking forward to your presentation. Mary-Jane, you may go ahead.
Thank you very much. Thanks for the introductions. So yes, as Kurt said, I'm presenting from East London, Eastern Cape, and I'm going to be doing the first part of the presentation before I hand over to Jaqui. And this evening, we're delving into Quervain's Tenosynovitis. So by the end of this evening, I'm hoping from my part of the presentation that you're going to have a better understanding of what Quervain's is, the anatomy involved in Quervain's, what are the triggering and causing factors, as also having a grasp of what splinting options that you may have. So what is Quervain's? This is also often referred to as mommy's hand or mommy's thumb because of the prevalence in new mommies. It's a painful condition that often affects the thumb side of the wrist, or otherwise known as the radial side of the wrist, and the two tendons on that side. It is characterized by pain and inflammation and is caused by repetitive actions, which we'll talk about later. And this is why it's classified as a repetitive strain injury. So pain is often felt when turning or flexing or ulnar deviating the wrist, grasping objects, and actions which involve resisted thumb extension, abduction, as well as pinching. The patients often report that they feel like a stabbing or a pinching pain, and it often refers, up the arm. The area just distal to the anatomical snuff box over here can often present with visible inflammation and maybe hot to the touch. So in order to understand the Quervain's, we need to have a good grasp of the anatomy involved. So on the posterior aspect of our forearm, we have 6 anatomical or compartments, and these house the long extensor tendons that belong to the muscles in the forearm, and their role is to transmit those tendons into the wrist and the fingers, They also then facilitate the correct trajectory of the tendon so that you've got the correct anatomical exertion of the tendons. Each of those compartments is lined with a synovial sheath, which then helps the tendons to run nice and smoothly to allow for smooth exertion. And they're separated by a septa. Each of the compartments are then held on the top part by a retinaculum, which I kind of think of as like a bangle that holds everything together. So with the Quervains, it involves one or both of the tendons that are housed in that first anatomical compartment. And those tendons would be your EPB and your APL, in other words, your extensor pollicis brevis and your abductor pollicis longus. That first dorsal compartment lies just proximal to that anatomical snuff box there, and it lies over the radial styloid. It's around about 2 centimeters in length. So if we think about these two tendons that run through that compartment, we've got to think about what the actions of the muscles are that are involved, because that gives us an idea of what the triggering movements are in the Quervains. So your EPB, if we just think about that muscle, it originates from the distal third of the radius, as well as the interosseous membrane between the radius and the ulna. It then goes and plants in at the base of the proximal phalanx of the thumb. Its action then is to extend the MP joint of the thumb. Because it passes over the CMC joint of the thumb, it aids in CMC extension as well. Then that APL, that originates from the proximal part of the radius and the ulna, as well as that interosseous membrane, and it comes in and plants in on that distal aspect of the thumb metacarpal. The main action of the APL is to abduct the thumb, again, because it passes that joint. It aids in CMC extension. It aids in wrist flexion as well as wrist radial deviation. So it's important to know what the actions of those muscles are, because it gives us a clue in terms of what the triggering movements are for the Quervains, as well as what would put stress and strain on those tendons. Just an important aspect with the de Quervains and looking anatomically at that first dorsal compartment, and what's quite interesting is that we always think of a tendon as a single strand, or as like a string, is what I always tell my patients. But with the Quervains in that APL and EPB tendon, is some people have an anatomical variance where it's not one single tendon strand, but they get split into multiple little strands as it runs through that tunnel. And people that have multiple stranded tendons, obviously you can think that it kind of fills up that compartment, and it makes the space in which they have to run through a little bit restricted. So people with multiple stranded tendons have a higher disposition of getting de Quervains, as well as if they then do have inflammation, it fills the space even more, which makes the condition harder to treat. So I've often found that people that have a multiple stranded tendon don't respond as well to conservative management as those who don't have the multiple strands. Unfortunately, the only way of really knowing if you've got a multiple stranded tendon or not is discovered either in surgery or with imaging. Okay. Sorry. So now we're going to move on to thinking about some of the causing factors. So we've looked at what the two tendons, muscles involved with the Quervains are. Now you've got to think about what actions are there, or what lifestyle things are there that cause de Quervains. And we know already that it's known as mommy's thumb, so it's most prevalent in young mommies. But literature says that it's most prevalent in women between the age of 30 and 50. Now, I still consider that young because I'm on the back end of that range, so it's still young. But it's mostly women between the age of 30 and 50. And it's also prevalent in people that are involved in occupations that involve repetitive wrist movements or resisted thumb extension and abduction. So if you think about what the two actions are that the muscles do, it would be any of those actions that are repeated, resisted, or stretched that would be a causing factor. So now, despite what literature is saying that it's the most prevalent in women, interestingly enough, I found personally, during COVID, there was a spike in young men that were coming to our clinic with de Quervains. And this was due to poor home gymming techniques. I had a young accountant who came to me with a very bad de Quervain. So if you think back to that very first picture where I showed the inflammation over that first dorsal compartment and how puffy it was. His was probably sitting about 2 centimeters high, the amount of inflammation that was there. It was hot to the touch, very acute. But essentially what we did is we looked and we analyzed his home gymming techniques, and he was doing some weightlifting and some kettlebell swings in between his work sessions just to break things up a little bit. And we looked specifically at the techniques that he was doing. And when we looked at the kettlebell swings, we analyzed how he was doing it. And it was definitely, that was the provocative thing. That was 100% to blame. So when he did his kettlebell swings, he was flexing and ulnar deviating the wrist, which stretched the EPB and the APL under load. He would then, on the forward swing, radially deviate the wrist up, compressing that EPB and APL tendons, as well as in overusing them. This repeated action over time caused irritation and inflammation, resulting in the Quervains. So he was a spanner in the works that throws that prevalence in women and new mommies. He was an accountant gymming at home. So now if we go back to those new mommies, these two ladies over here, where literature puts it, and actually overall in my clinical experience, that's where we see it the most. If we analyze what they're doing, they are continually lifting up their babies with their thumbs abducted and the wrists moving from ulnar to radial deviation, as well as when they're holding their babies. That bottom hand, the wrist is held in flexion with ulnar deviation, with the thumb stretched out in abduction and extension, putting a hang of a lot of strain on those tensions. And doing this over and over and over, putting load and stretch on those tendons, causes irritation, resulting in the Quervains. We can look at another population that nowadays is presenting with Quervains, and that's our teenage population. And that is their addiction to the phone that is the causing factor. So if you think about those teenagers that are continually scrolling with their thumbs while holding their wrists in relative flexion with a little bit of ulnar deviation with the weight of the phone, it's an overuse disaster waiting to happen. So with all of these people, the repeated load can lead to stenosis or narrowing of the compartment, thereby limiting the amount of motion that the tendons have through the compartment, because it's narrowed even further and it puts further strain on the tendons. This ongoing inflammation and scarring can then lead to the tendons themselves becoming attenuated, which basically means thickened and hardened. And it, again, limits the amount of space that there is to glide through that little tunnel. And this can become a chronic problem and can actually even reduce your range of motion, which we'll talk about in the next slide as well. You'll see it with one of the provocative tests. Because if that tendon becomes hardened and it's not able to exert through the tunnel, it's going to limit your flexion of your wrist, ulnar deviation, as well as flexion of your thumb. So now if we're looking at provocative tests, so ways you want to assess to see if a person has the Quervains, there are lots of them out there, but probably one of the most well-known is your Finkelstein test. The Finkelstein test, what you do is the thumb moves into the palm, into flexion, it's held by the fingers, the wrist is then ulnar deviated. If the patient reports pain that is similar to the pain that they've been experiencing, it's a positive test. So what's nice with this one is quite often when they bring that thumb into the palm and the wrist into flexion, if it's a chronic condition and there's attenuation of the tendon, they have limited range into the flexion or that bend position as well. You can also use palpation over that first dorsal compartment. With a palpation, you're feeling for attenuation or hardening of those tendons, you're feeling for inflammation, and obviously some pressure on the tendons might be painful for the patients. Then you're doing resisted extension and abduction of the thumb. It's obviously resisting the two motions that those two muscles are primarily responsible for. Pain with resisted movement is a positive response. I like to in any way do these two provocative movements just because it gives me an indication of if there is one of the two muscles or tendons that is more problematic than the other, it also gives you an idea of what kind of movement they've been doing on a repeated basis that's been a cause. Okay, so we need to talk a little bit about splinting. Jaqqui's going to be delving into more of the management, the overall management, but I'll be touching on splinting. So if we think there are a number of ways that we can treat the Quervains, and there's often not just one way, but it's rather a multimodal approach. And Jaqui, like I said, will be going more into the management of the Quervains, but I'm going to touch on the splinting. And there are a number of aspects that we need to consider when we are choosing how and if to splint the Quervain patients. So if we consider the two tendons that are involved, we know that they pass both the wrist and the thumb. So our splinting likely needs to involve, or at least one or both, but in the very least the wrist. We also need to think about the triggering movements, and we want to prevent the excessive flexion and ulnar deviation at the wrist, as well as the compressing radial deviation. And we want to prevent the resisted extension and abduction of the thumb, but still allow for function. So consideration into how severe the pain is may guide us in terms of the amount of support that we need to provide. If a patient has an excessive amount of pain, we might want to then consider a period of relative immobilization. And how a person needs to use their hand during the day is also a definite thing that we need to consider. So for example, a new mom who has this newborn baby that they're handling, even if they have very severe pain, is very unlikely to use a hard thermoplastic splint and would probably benefit more from soft splints. Whereas that gym bunny that I spoke to you about, he spends most of his time at the desk during the day, so he could function with a thermoplastic splint. So you just need to think about what is practical for the patient, what is actually going to work. You also need to then consider the patient's financial position, as well as your own resources, as these may dictate what splint you're going to provide, and if you're going to provide a splint. Ultimately, whatever you choose, as long as it has the desired effect of supporting or immobilizing or being a visual cue to aid recovery, you can't really go wrong. So if we talk about the different splinting options that we have, we've got hard splints. The hard splints can be your custom-made thermoplastic splints or your off-the-shelf splint. So to consider the hard thermoplastic splint, it's usually if a patient's got a lot of pain, if it's an acute episode, if they are able to work or do their ADLs with the splint on, or sometimes just for night use, because patients wake up with a lot of pain with the Quervains because of that fetal position, that fixed position that we're sleeping in. We're putting stretch on those two tendons at night. Your affordability and your resources is also a consideration for your hard splint. So I can tell you personally from my own clinical perspective, in the beginning, a couple of years ago, I used to splint all of my de Quervain's patients with a hard splint. I do less and less now. There is definitely a place for it, especially if they've got a lot of pain and it's a very acute episode. I may sometimes put them in a hard splint at night and a soft splint during the day. But generally, personally now, less hard splinting. Then you've also got your off-the-shelf hard splints, like the wrist brace here. You also get off-the-shelf thumb spiker splints. I don't really like the off-the-shelf thumb spikers because I find they generally hold the thumb into the extension, but you do get some good ones. Then you get soft splints. These are usually made with Nqwena Pro Wrap or neoprene wrap. I love the Nqwena and the Pro Wrap, and I'll explain why in a little bit. But you'd consider using the soft splints if there's less pain, they're unable to manage or can't use a hard splint. When they're weaning from the hard splint, or as a visual cue into some of the activity modifications or the way that they need to change the way they're doing things, which I'm sure Jaqqui's going to chat about a little bit later. So the Nqwena wrap and the Pro Wrap, the reason why I really love them is that rubber coating that they've got on the inside of it. So if you think of those patients that have got that chronic inflammation or even acute inflammation, With inflammation, you get scarring. With scarring, you get adhesions. So you may have adhesions within the compartment, from the compartment to the fascial layer to the skin layer. Best way to get rid of adhesions, one of the best ways, is mobilization. So if you've got that new stem wrap sticking onto that area, every time you move, it almost massages the skin. It loosens up those fascial layers. So I really like it. It's also got a compressive element, which works on those superficial pain receptors. So soft splints for the Quervains, nowadays, for me personally, that's generally how I go with Cape tape included. So moving on to Cape tape. So Cape tape, depending on how you apply the tape, is what it does. So you can use the tape to limit the flexion, to support the thumb, to open up space, to deactivate the muscles, or to detension that skin to help with that adhesion, and to open up space. So tape considerations is if they've got less pain, if you're wanting to give proprioceptive feedback, also helping in that rehabilitative phase where you're trying to teach certain things. If they're unable to use hard or soft splints, and also if they're financial constraints, because the tape is generally quite a lot cheaper, and there are alternatives as well. So if you're wanting to give support, but you don't have access to tape, you can use something like micropore. It would act as like a rigid tape. So I've got some videos about 2 taping techniques that I often use with the Quervains, but like I say, there isn't one technique that you can use. If you know what you want to do with the tape, there's so much that you can do. And then, of course, there's the option to not splint. So not splinting would be if there's not too much pain, you're at a rehab or a maintenance point, you don't have the resources to splint, or actually sometimes even if it's a very chronic case, I would opt not to splint. So I've got 2 pattern examples here of splints that we use in our practice. So if I were to make a hard thermoplastic splint, this is a pattern that I sometimes use, the radial thumb spiker, or I draw my own pattern. Or if you're using Orphicast, like what was in the picture example that I had, you just kind of squeeze it and cut it. But here's a splint pattern. I've got a little video of how to use this pattern, or I'll be using that little pattern. And then this one is the wrist wrap. Very, very simple. Okay, so the radial thumb spiker. This is just a quick video of me making it, if it works.
Okay. All right, so I'm going to demonstrate a radial thumb spiker with that pattern that you've been given. I like to splint with the patient's arm supported on the table with the arm in neutral. I then tell them to relax, get them to extend ever so slightly at the wrist, with the thumb into relative opposition with the index finger, and to just relax in that position. Sorry for the blank space. And then get the material. You are going to lay it on the radial side, making sure it's not too hot. Hopefully it's not too hot for Amy.
Fine.
And then you bring that around. And make sure that they've got good IPJ clearance there. Just shape in that position. And then you're going to have a strap, and a strap.
So just to say as well that you just need to make sure that your splinting principles apply here. You want to make sure that you've got good distal palmar crease clearance, just so that they can get good MP flexion there. I already commented in the video about the IP clearance. And then just on the posterior aspect, you just want to make sure that the ulnar styloid is also clear, using your principle of 2/3 of the length of the forearm. And then for me personally, getting that good opposition for function is important.
Okay.
Oh, sorry. Okay, then just 2 quick videos on 2 of the taping techniques.
Okay, Okay, I'm going to show you two different techniques for taping for the Quervains that I use often. The first, you're going to need 2 strips of K-tape and 1 little band. So the strips are about 4 blocks long, and the band is about 1, just slightly over 1. So you're going to start off with your strips. Going to make a little tear, fold the paper back, pull this one off. Going to stick it over here, and we're going to do the pink lady ribbon or the figure of 8. So I'm putting no tension. I come underneath that MP, pull my paper back. I'm going to come with tension and stick it on. Okay. The second piece is to just, if you haven't got enough support at that MPJ, you're going to position it slightly differently to give good support at that MP joint. You can even support it more by getting the patient's hand into it, or the wrist into a little bit of extension, because you will see just now when we finish taping what the tape does. So again, going to follow that same sort of path, but I'm going to come a little bit further underneath the MP this time. Come around and stick. So I'm tensioning with quite a lot of tension this way around so that it pulls that MP joint up. This guy here is to open up the space over that first dorsal compartment. So you're wanting to lift it to alleviate the pressure. So what we're going to do then is tear the tape halfway through, fold back the paper, you're going to stick it over that first dorsal compartment, and then you're going to pull back on the ends so that they are going to recoil and lift up to give space in that first dorsal compartment. Okay, so if you try and bring your thumb down, can you feel it's restricted?
Yes.
If you try and bend your wrist forward, can you feel there's a little bit of restriction there?
Yes.
Okay, so it gives quite a lot of support at the thumb, and it definitely, if you try and ulnar deviate your wrist, it's going to restrict you. Okay, so you are therefore limiting the amount of flexion, ulnar deviation, and then also the amount of flexion of the thumb and combined flexion and ulnar deviation of the wrist.
Okay, and then this little guy, last one.
The second technique that we're going to use is to deactivate the 2 muscles. So both of those muscle bellies, you'll remember from the anatomy part, sit over here in the forearm. One of them plants in down here, and the other one plants in up here. Okay, so hence I've got 2 tails, so that you can stick them onto around about where those 2 tendons implant, and then come down. If you're wanting to detension a muscle, you always start at where it ends, and then give tension towards where the muscle belly originates from. Okay, so we're going to tear it where the tails are, and pull off. And we're going to stick it on where those 2 tendons implant, with no tension. Peel back the tape, and bring the wrist again into a little bit of an extended position, and we're going to come back to where those muscles originate from, and that's how you would detension. You can use the 2 tape techniques in combination with one another, or you could even just put the one that detension, that gives you space over that first dorsal compartment together with that. So this deactivates the muscle, but also, because we brought the wrist into an extended position, is going to make it a little bit more tricky to come into a flexed and an ulnar deviated position.
Okay, so those are 2 taping techniques that you can use. And that brings me to the end of my portion of the presentation. I hope it was useful, and I'm going to hand over to Jaqui now.
Thank you so much, Mary Jane. And
Yeah.
I will now like to introduce our second speaker, Jaqui Eksteen. Jaqui, if you wouldn't mind starting your video. I've known Jaqui for quite some time. She studied at the University of the Witwatersrand and then went on to work at Head and Joseph Hospital in Johannesburg for 12 years. She completed a research master's degree at Wits University, and she developed an occupation-based assessment and treatment program for patients with de Quervain's. And then in her research, she compared the outcomes of this program to a traditional or routine care program that was offered within her setting. So Jaqui has a very keen interest in this topic. Jaqui has recently moved from the public sector into private practice and now runs her own private practice in Johannesburg. And she's also a dedicated wife and mom, and it's a real pleasure to have you share with us this evening. Thank you, Jaqui.
Thank you, Kirsty. Hi, everyone, and thank you, Kirsty, for that lovely introduction and for the invite. I'd also just like to take this opportunity to acknowledge Kirsty, who was an incredible supervisor during my master's degree. Your guidance and support were invaluable, and I'm very grateful for everything you contributed to my learning and development. My presentation this evening will focus on both the conservative and post-surgical management of de Quervain's tenosynovitis. So what I hope you all take away from this presentation is a clear understanding of the conservative management strategies for de Quervain's, an understanding of the indications for surgical intervention, the ability to outline key principles for post-surgical rehabilitation and functional recovery, and the capacity to apply evidence-based strategies to optimize patient outcomes. So conservative treatment methods are typically the first line and most preferred options for managing de Quervain's. Conservative interventions include pharmacological management, immobilization through splinting, patient education regarding the condition, activity modifications, as well as the application of joint protection and energy conservation principles. Additional approaches such as therapeutic modalities and manual therapy techniques are also commonly used. Through my own clinical experience and from clinical trials, it is shown that patient outcomes are significantly improved when a combination of these treatment modalities are used, rather than a single intervention in isolation. Each of these methods will be discussed in detail in the following slides. Okay, so non-steroidal anti-inflammatory drugs and corticosteroid injections are the most commonly used pharmacological treatments for de Quervain's, which are usually prescribed and administered by the patient's medical doctor. Corticosteroids involve injecting a corticosteroid combined with a local anesthetic into the tendon sheath of the first dorsal compartment of the wrist. If patients experience some relief of symptoms but still report discomfort and pain around 4 to 8 weeks after the initial injection, an additional corticosteroid injection is usually administered. So research shows that corticosteroid injections are about 70% effective in alleviating pain, provided that this procedure is done accurately. However, while these pharmacological interventions can reduce inflammation and pain quite quickly, they do not address the root cause of the condition and generally tend to have short-term effects. There is also a risk of developing post-injection complications, which is just something for patients to be aware of before administering them. Okay, so in 1895, Fitz de Quervain, who initially described this condition, 1st introduced immobilization as a treatment option for de Quervain's, and it still remains the initial management approach used by most OTs during first consultation with patients. So a thermoplastic thumb spiker splint, as described in Mary Jane's presentation, is fabricated for the patient. This splint positions the wrist in neutral and the thumb in approximately 30 degrees of palmar adduction, while leaving the thumb IP joint free to allow mobility. So the primary purpose of the splint is to immobilize the wrist and thumb, thereby reducing ulnar deviation and thumb flexion, both of which contribute to friction and irritation of that APL and EPB tendons within the first dorsal compartment. So it is recommended that patients wear the splint mostly at night and during the day when they don't need to use their hands for certain functional activities for a period of approximately 6 weeks. If symptoms persist beyond this period, extended immobilization may be considered until adequate pain reduction is achieved. Once the patient's pain has subsided, a soft splint can be introduced to facilitate gradual weaning from the thermoplastic splint, while still providing functional supports during daily activities. The splinting provides comfort and relieves pain. However, as I mentioned with corticosteroid injections, immobilization alone only addresses the inflammatory process and may not provide long-lasting pain relief, as patient symptoms often return when the splint is removed and they return to their everyday activities. So splinting should always be used in conjunction with other treatment modalities, which I'm going to discuss in the following slides. Okay, so as therapists, we all know that our patients' understanding of their condition is absolutely essential to ensure compliance to treatment protocols and for improving therapeutic outcomes. Therefore, it is important that we conduct an in-depth education session with all our patients to cover the medical understanding of the condition and its impact on their everyday functioning, and to establish realistic expectations for recovery, as well as to define our role in the management process. And this will really foster a collaborative approach to care with our patients. Okay, so when educating our patients on activity modifications, a client-centered approach is essential, as these adaptations must always be tailored to their unique roles, routines, and life context. So first, we are going to ask our patients what activities they perform in their everyday lives that exacerbate the pain, and brainstorm with them on how their occupational environments, their tools, and activities can be adapted to limit pain and discomfort. Specifically for the Quervains, activity modifications should basically aim to promote a neutral wrist position and limit excessive thumb movements during daily tasks. It's important to teach proper lifting mechanics and, where possible, encourage the use of ergonomically designed hand tools with modified or built-up handles to reduce strain on the affected tendons. So as a former sufferer of de Quervain's myself, I've decided to use my own experience as a case study in this presentation. So as shown in these pictures, I invested in a pair of ergonomic splinting scissors to reduce strain on my thumbs, as well as this ergonomic workstation for my laptop. When I made these changes, I noticed a significant improvement, which is a testament to the impact that small, meaningful activity modifications can have on managing this condition. You can also encourage patients to bring along their own tools and materials they use in their daily occupations to the session to enhance and practice these task modifications. And if it is appropriate, you can also perform an ergonomic analysis or vocational assessment of the patient's job and suggest possible reasonable accommodations for their work tasks. Okay. When you're teaching joint protection and energy conservation principles to your patients, it's really helpful to show them how to perform some of these strategies during the session and then give them the opportunity to practice them. So for example, if you're teaching a patient how to correctly lift their baby in a way that reduces load on the APL and EPB tendons, begin by demonstrating the movement yourself, then allow them to practice it under your guidance. And if resources are available, it's also helpful to provide a handout outlining these principles, ideally with photos as part of their home program. I've put together 2 handouts that include activity modifications along with joint protection and energy conservation strategies, all specific to the Quervains, which Nicola has kindly attached to the email you received today for your reference. These handouts also include pictures which help illustrate some of the concepts. And there is also a section with step-by-step instructions on how to make your own low-cost jar opener, as well as a video demonstrating this. Okay, there are a few therapeutic modalities that we can use for the management of the Quervains. And these include thermal modalities such as paraffin wax baths or heat packs, which can be used to increase circulation and soften surrounding tissues, making them useful in the subacute or chronic stages of the Quervains. In contrast, ice packs are helpful in the acute phase as they reduce inflammation, swelling, and pain. Taping and strapping is another popular technique used by many therapists. Kinesiotaping, dynamic taping, or cohesive bandage are generally what most therapists use. Taping helps to limit thumb or wrist movements. It offloads the tendons and reduces irritation, pain, and inflammation in the first dorsal compartment. It also provides proprioceptive feedback, which helps the patient become more aware of their hand position and movements. There are many online resources on the correct techniques of applying these tapes for the Quervains, and some companies like High Tech Therapy also provide in-person training if requested. Other therapeutic modalities described in literature include ultrasound therapy and electrotherapeutic interventions such as TENS. However, I have not personally used these modalities in my practice. Okay, there are a number of manual therapy techniques we can use for the management of the Quervains. The first being soft tissue mobilization over the lateral aspects of the forearm, as well as the first dorsal compartments of the wrist. This is aimed at reducing adhesions, improving circulation, and relieving muscle tightness. There are different techniques we can use, including longitudinal massage, cross-fiber friction massage, where you apply pressure perpendicular to the tendon sheath, as well as myofascial release. Tendon gliding exercises with passive assistance involve slow and gentle movements of the APL and EPB tendons by passively moving the thumb through flexion and extension, as well as abduction and adduction while stabilizing the wrist. And this helps to restore smooth tendon movements. If there's any neural irritation or entrapments contributing to the patient's symptoms, nerve glides may also be performed, and radial nerve glides in particular can help if there is tension along the lateral forearm. If you have received training in lymphatic massage, manual lymph drainage techniques may also be used to address localized swelling. Alternatively, Quervain application offers an effective method for managing edema in this area. Okay, so once the patient's pain has subsided, isometric loading exercises targeting the APL and EPB can be gradually introduced. And as tolerance improves, these can be progressed to eccentric strengthening to restore function. Okay, so as the majority of you attending this webinar are occupational therapists, we all know that for improved therapeutic outcomes, we need to ensure that our treatment approach is always occupation-based, holistic, and client-centered. So I'm going to share a case scenario from my own clinical experience that highlights the practical application of these strategies. that are displayed on this slide. I recently worked with a female patient presenting with de Quervain's who came from a cultural background where she was the primary caregiver for young children and was expected to manage all domestic duties, including cooking, cleaning, and washing. As part of her conservative management plan, I initially recommended a thermoplastic splint, activity modifications, and rest. However, she expressed concern about being unable to reduce or delegate her responsibilities due to strong cultural expectations and limited family support. I then had to adapt my treatment approach to better suit her daily routine. And instead of emphasizing complete rest, I focused on practical joint protection strategies she could use during childcare and cooking. And I provided her with a soft splint to allow for greater hand mobility while still offering some level of support. Also recognizing that English was not her first language, I also provided handouts translated in her home language to support her understanding and adherence to the treatment plan. And throughout our sessions, I made a conscious effort to acknowledge her caregiving role and the cultural expectations placed upon her without judgment, ensuring that she felt heard and supported in her care. Okay, now we are going to look at the post-surgical management of de Quervain's. Okay, surgical intervention for de Quervain's is usually only advised if there's persistent inflammation after failure of 3 to 6 months of conservative management and at least 1 corticosteroid injection. Surgery involves release of the first dorsal compartment and decompression of the APL and EPB tendons. Although studies show that the outcomes for surgical release are relatively good, patients should be informed that certain complications such as volar subluxation of the APL and EPB, radial sensory nerve injury, scar hypertrophy, as well as complex regional pain syndrome may also occur. Occupational therapy is often essential following surgery to optimize functional recovery and prevent complications. The typical intervention plan includes thumb spiker splinting for about 7 to 14 days for comfort and to protect the surgical site and allow healing. Maintaining range of motion of the unaffected digits and the thumb interphalangeal joint. Early mobilization starts around day 2 post-op, where we begin with gentle range of motion exercises for the thumb to prevent stiffness and promote mobility while still wearing the splint in between exercises. Edema management includes elevation of the hand, compression, and active range of motion exercises to promote lymphatic flow. Scar management is commenced once the wound has healed and a scar forms. And this includes scar massage to reduce adhesions, application of silicone sheets or gels to flatten or soften the scar, and if appropriate, fabricating pressure garments. Okay, at 1 week post-op, we can begin with low resistance strengthening exercises and gradually increase resistance based on tolerance and the healing progress. If hypersensitivity is present, you can initiate desensitization techniques to normalize sensation. Unrestricted activity is generally allowed from 6 weeks post-op, depending on healing, and splinting or taping may be recommended for high-risk activities or repetitive wrist and thumb motions. And lastly, all intervention techniques that are outlined in the conservative management section can also be applied post-operatively with appropriate modifications based on the stage of healing and the individual patient needs. And that's in the presentation. Thank you.
Jaqui, thank you for a fantastic presentation and for very practical examples of its application. And thank you also for your handouts. that are going to be super helpful. We really appreciate that. We have a little bit of time left, and perhaps I can pose this question to you. How would you differentiate de Quervain's from an early arthritis of the CMCJ of the thumb or arthritis in the wrist?
Okay. I think doing the Finkelstein test as well as the I think it's called the Watt test now. It's basically where you position the wrist in flexion and you resist abduction of the thumb, and that causes, it's a very provocative test, so it causes extreme pain. And patients usually don't have that type of pain with arthritis. And also with de Quervain's, you have a more radiating pain down the forearm and up the thumb, whereas with arthritis, it's generally localized to that base of the thumb. And if you're really not sure, you can always send the patient for some x-rays or to an orthopedic surgeon for some x-rays, just to see what's going on with the joint space.
Can I add on to that?
Yes.
Please go ahead, Mary Jane.
Yeah. I think just also a good clinical history that you take from the person before you do the provocative test, in terms of how long the pain has been there and when specifically they get the pain, with what type of activities. A nice test that you can do for osteoarthritis at the CMCJ is the crank and the grind test. They're not nice for the patients if it's positive, though. Let me just see if I can quickly turn on my video and then I can demonstrate. Okay, so the crank and the grind test is basically you axially load the thumb. So you put load into that CMC joint. The grind test is you just move that CMC into like a circular movement. Pain there would be a positive response for CMC arthritis. The crank test is again actually loading and then flexing and extending at the MP joint. And again, pain would be a positive response. So that isn't usually painful with the de Quervain's patients. But you may have a de Quervain's and CMC arthritis together. Yeah. So CMC arthritis, the dorsal radial sensory nerve irritation, de Quervain's, the intercession syndrome, those are all your differential diagnoses.
Yeah, and I think feel free, if you are a generalist therapist, feel free to reach out to an experienced hand therapist, or if you have access to an orthopedic surgeon or other hand surgeon to assist you with differentiating between differential diagnoses. I think there's a similar question around a ganglion cyst in the chat, and I think exactly the same. It's your history taking and using all these provocative tests to be able to narrow it down, but reach out when you need help. We have time for one last question, which I'll pose to both of you. Someone asked, how long do we splint for? And I'd like if you could share just some of the considerations that would inform your clinical reasoning around deciding how long to splint.
I think I typed a response in the chat as well. And it's such a difficult question to answer because I think it is based so much on the clinical presentation, the patient's life circumstances, and what your treatment is that you're choosing. So for me personally, there isn't a recipe that I can give you. It's based on that. But if I have to be forced into giving you a recipe, if it's a hard splint, generally, I would say 2 weeks of full time. I would err on not going beyond the 2 weeks full time in a hard splint. I would then put them in the hard splint only at night for a further 4 weeks to get to that 6-week period, but then progress them into a soft splint. Soft splint, because you're not immobilizing, I would go for longer. So for me, it's different to protecting a healing fracture or protecting a healing tendon that's been severed. It is a healing tendon, but in a different sense. I think to a certain degree, you want mobilization in that compartment because it's already so gunged up and stuck. So that would be my clinical reasoning and how I clinically reason things out. But I know there are some literature that point towards having a longer period of immobilization.
Thank you so much, Mary Jane. I think it's so helpful to hear the factors you're taking into consideration, because I know some of our surgeons also ask for 6 weeks of splinting for our patients. So it's really helpful to get that input. Jackie, what would some of your considerations be?
Okay, so most of the literature recommend 6 weeks, but I would agree with Mary Jane. It also depends on the severity of the pain, the patient's pain. Some people have mild pain, some people have more severe pain. Also how long they've had the condition for. So, if it's a more mild pain, I would, err on the, shorter period. But if it's quite a severe pain, or if they've had it for longer, they may need to have the splint for a bit longer. And as Mary Jane said, also, it doesn't have to be 6 weeks full time. You can wear it at night or during activities, or I think it depends on the patient's situation and their case and their level of pain.
Yeah, thank you so much. And I think as a generalist therapist or a very young therapist, it's hard to know that one needs to be taking all these things into consideration. So again, if that's the position you're currently in, reach out to a mentor. I know within South Africa, there are many people that are willing to mentor, to just bounce off these questions with, and to glean some of those reasoning factors to help build your own clinical reasoning. We are at 8:30, and I just want to say a very, very big thank you to both Mary Jane and Jackie for incredibly full and practical and clear presentations. We really appreciate you sharing your expertise, and I trust that this is going to be a help for all of us in managing our patients well and collaboratively putting together good treatment plans together for them. So just to remind you that the webinar will be made available on YouTube in time, along with all our other past webinars. And please feel free, or we encourage you to share this with others who have missed previous webinars. And then our last webinar for the year is on the 4th of November, and we're going to look at the proximal phalanx predicament, how to regain motion and function after an extra-articular fracture of the first phalanx. So we very much look forward to that last session of the year. It's hard to believe we're talking about the last session of the year, but we look forward to seeing you then in November. Thanks, everybody. Hope you have a really good evening, and see you next month.